So good evening. Before we're going to sleep, I will bother you with this last presentation today. Today I'm talking about sleep-related movement disorders, and tomorrow morning I will talk about movement disorders related sleep disorders, and you will see it's an entirely different story. This is a very kitschy picture of Zurich, and I'm very honored and happy to be here in Vietnam to talk about those issues. So what are sleep-related movement disorders? You will recognize that even specialists are not really clear in saying what is defined as sleep-related movement disorders. This is the International Classification of Sleep Disorders, the third edition, which is currently valid. And here you see a list of sleep-related movement disorders in adults. So we talk much about restless leg syndrome because there is no other talk about restless leg syndrome here at this conference. We will talk about PLMD, periodic limb movement disorder. There is also sleep-related cramps, sleep-related bruxism. More in children than adults, there is an entity called sleep-related rhythmic movement disorders such as body rocking or head banging. I will not touch this today because of time restriction, but we will also talk about propriospinal myoclonus at sleep onset here. So the first topic is restless leg syndrome, and I will spend some slides to this entity because it is very common. So the prevalence, according to several studies, is in the mid single number percentages, above 5%, more frequently in women than in men, and it is more common in the elderly. But this slide clearly shows, and you see here the age, very small numbers. You see it can also occur in younger people, so it's not restricted to the elderly, it's more common in the elderly. The diagnostic criteria are still the following, showing that you can diagnose restless leg syndrome just based on the history you get from the patient, and you will have to look for the 4 criteria here. So there must be an urge to move the legs, and this can be associated with unpleasant sensations, pain, or other sensations in the legs. The whole thing starts as soon as a patient rests, sits down or lies down, and it is worse in the evening or during the night. So there is some diurnal variation, a circadian pattern of the disease. And the most important one is the last one here. When the patient starts to move the legs, the symptoms get better. So there is relief by movement. Those 4 have to be present, all of them, and then you can suspect or even diagnose restless leg syndrome. So this is now just a video showing that. It was courtesy by David Rye, so he gave that to me some years ago. You recognize Charlie Chaplin here. He's going to bed, fulfilling one of the criteria, lying down, fulfilling the criteria, and there seems to be some urge to move the legs. We do not really know whether it gets better when he moves the legs, not for his neighbor, but based on what we see, could be restless legs. You know that restless legs don't look like this, but just based on the letters. On the other hand, this is a real restless legs patient. I hope that the video works. It did before. So that's again the problem with technology, but this also occurs in Switzerland. So what you would see in this patient, he is really ill-tempered and he starts hitting his back, he starts hitting his legs, he's moving the legs, then finally sits at the corner of the bed, gets up and starts walking. So he seems to have a restless body disease, not only the legs which are troubling him. And he also works with the hands all the time, showing that restless legs must not necessarily be restricted to the legs. But this shows that the 4 criteria can be difficult. And therefore, if you have doubts, you may consider supportive criteria. And here they are. One is that in most patients with restless leg syndrome, there is a positive family history, not always, but in most patients. You can try and start a treatment with dopaminergic agents, and patients should report that the disease gets better. And you can finally refer the patient to a sleep clinic to do a polysomnography, and there you should see periodic limb movements. So if you have all 4 mandatory criteria and none of the supportive criteria, then I really advise to doubt the diagnosis of restless leg syndrome. So how do periodic leg movements during sleep look like in the polysomnography? So this is a polysomnographic window. Here you see here the eyes, you see the chin EMG, you see here the EEG, and here you see the EMG of the legs and of the arms. And you can see the patient is in S2 sleep stage here, and you see a periodic repetitive burst of EMG activity here, which is reflecting periodic limb movements. It's not only legs, it's also in the arms, and therefore it's periodic limb movements during sleep here. If you start treatment, you would like to know about the treatment success. What you can do, you can apply a questionnaire. The IRLS questionnaire is widely available in many languages. It's a Likert scale-based questionnaire from 0 to 4 for every symptom. It's 10 questions, and you end up then with these numbers, and then you can say whether your patient suffers from severe, very severe, moderate, or mild restless legs, and you can find out whether treatment has some effect based on this questionnaire. This is a very, very busy slide, and without reading it, you can see on the bottom of this figure here lots of symptoms that may occur in patients with restless legs during daytime. This is just saying that restless legs is not only a disease of the night. If you have a bad sleep, you have also problems during the day, like being tired, irritability, problems at work, school. Also, sleepiness is present in a subset of RLS patients. So you may want to ask the patient about his daytime functions as well. I won't lose a lot of words about the pathophysiology because it's still a myth. We do not exactly know what is behind restless leg syndrome. There are more and more studies suggesting and confirming that there is a disturbed iron metabolism in the brain. There are assumptions that the dopaminergic system is dysfunctional. It also looks like a circadian rhythm disorder with this clear prevalence or the clear occurrence of the symptoms during evening and night hours. In some studies, it has been related to abnormalities in the spinal cord, and there have been several genes being associated with restless leg syndrome. More important from a clinical view is the question, what can aggravate restless leg syndrome? And here is a list of things that should be avoided in patients with restless leg syndrome. So antidopaminergic medications can cause or aggravate it. Also gastrointestinal medications, for instance, metoclopramide. Then a lot of antidepressants can aggravate restless legs badly, and this is a tricky thing because many restless legs patients suffer from comorbid depression. Bupropion is a drug which has been tested and which seems to be pretty harmless for restless legs patients. Centrally acting antihistamines are also not very well tolerated by these patients. Non-steroidal anti-inflammatory drugs, neither sleep deprivation and alcohol should be avoided if possible. If you think about the differential diagnosis, then do not miss restless legs mimics because they exist, and also Wayne Henning and Richard Allen, who are some of the main competitors in the field of restless leg syndrome, clearly stated that these 4 diagnostic criteria are not sufficient to exclude other diagnoses, such as polyneuropathy, iron deficiency, pregnancy, and all those on this list here. And this list is not complete, of course. So if you have doubts, again, think about the supportive criteria and do other tests, clinical tests as well. How should we treat patients with restless leg syndrome? These are the brand new criteria which have been published this year in Neurology. There is level A evidence for efficacy for several drugs. Not surprising, it's pramipexole, rotigotine, both have level A evidence. You can use them in low dosages, and they are, in most patients, very well efficacious. Cabergoline is also very good in terms of efficacy. However, in most countries it's not used anymore because it can cause cardiac problems, valvulopathies, and therefore this is clearly a second-line drug in most countries. And now gabapentin has also level A evidence for the treatment of restless leg syndrome. There are other compounds that have been tested in several trials, and there is somewhat lower evidence, such as ropinirole, evidence level B, levodopa, which is not FDA approved for restless leg syndrome in the United States, but used in many countries for the treatment of restless legs. Pregabalin, also evidence level B. Then, of course, you do in most patients also look for iron levels in the blood, and if they are low or in the deep normal level, you supplement iron, and the evidence level for this treatment is B. And not approved in the States, but in the European Union. I do not know about Asia, unfortunately. Oxycodone, naloxone, these opioid treatments can be used with some success in patients with treatment failures. One of the tricky things in restless leg syndrome is augmentation. This is something that occurs in many patients and is difficult sometimes to diagnose and then also to treat. So what is augmentation? Augmentation is a worsening of symptoms on treatment. So this can be an earlier start of symptoms during the day. It can involve other body regions such as the hands, the arms, or the trunk. And the onset of symptoms can be more rapid. So if you have this, and if the patient also tells, well, I augmented my treatment dosage and it got even worse, then the diagnosis of augmentation is given, and then you should consider changing your treatment to either a break, which is not well tolerated by many patients, or change to another treatment. You can also change from one dopamine agonist to another. That's also possible. And which dopaminergic agents are most likely to produce augmentation? There is a clear evidence now that short-acting dopaminergic agents, including levodopa, are more likely to produce rapid augmentation than long-acting dopamine agonists. This is shown in this very recent publication of Diego Garcia Berraguero. You see here a steep incline with short-acting dopamine agonists and much less steep in patients who have been treated with long-acting dopamine agonists. And therefore, Diego writes in his review that nowadays we should even consider start treatment with gabapentin rather than with dopamine agonists to avoid augmentation from the start. You have to consider this for yourself and for every patient. In my opinion, it's a little bit hard to say, because I guess, based on my experience, that the dopamine agonists are still more efficacious than gabapentin. So now we switch to the second one, which is periodic limb movement disorder. What is it? Periodic limb movement disorder is characterized by the occurrence of periodic limb movements during sleep, PLMS. Those are repetitive, periodic or pseudo-periodic stereotype movements, often with a toe extension, with the ankle dorsiflexion. Knee and hip are often flexioned, and those movements last only a few seconds and occur every few to 90 seconds. And for the word periodic, you need at least 4 consecutive episodes. And if you have those PLMS, shown in a polysomnography, and the frequency is more than at least 15 per hour, and the patient suffers from sleep or wake problems because of the bad sleep, then you talk about periodic limb movement disorder. How does it look like? These are periodic leg movements. This would be periodic leg movements. Well, now I really would like you to see that. So let's go, and which one was it? Now don't look at the names. Here. Obviously, he doesn't want to play it here. That's a pity, because it's very typical. So you would see here, you can see it here even a little bit in the photograph, you can see the toe extension here, you can see the ankle dorsiflexion, you can see that the patient moves very slightly his leg by bending his knee and hip. That's what you would see. So now let's go to the presentation. One thing that is puzzling us all the time is what's the clinical significance of this treatment and what are the clinical consequences. So there have been studies associating periodic limb movements during sleep with cognitive decline, with high mortality. It's all a little bit controversial, and if we talk about clinical treatment, it gets not better. So there is the last recommendation of the American Academy of Sleep Medicine. There is no recommendation, you can see in bold letters here. There is insufficient evidence at present to comment on the use of pharmacological therapy in patients diagnosed with PLMD alone. So what you can do if you have a patient suffering from it because he has or she has problems to fall asleep or to sleep through, or is tired during daytime, you can try dopaminergic agents or gabapentin or whatsoever, but there is no good evidence for that. Now, a very rare disorder, propriospinal myoclonus at sleep onset. What is it? Most of you probably have never seen it because it's really rare. So this is defined as the occurrence of repetitive axial jerks, which are slowly spreading mostly downwards, but also to some extent upwards, and they usually start in a thoracic myelin level. Important is that those events occur when the patient falls asleep, so in the wake-sleep transition, and it can even lead to falls out of the bed. So that's a very rare type of a spinal myoclonus with a very slow propagation up and down the spinal cord. There has been a nice overview on reported cases so far, and there are not many. And based on these cases, there are three types which are currently distinguished. One is the idiopathic form, which occurs at this sleep-wake transition or wake-sleep transition. This is more than 80% of propriospinal myoclonus at sleep onset cases. Then there are symptomatic cases and functional cases. There are several reports from Netherlands, for instance, for functional cases. And you can find in this overview paper a table on all these clinical spectrum characteristics, and for the symptomatic propriospinal myoclonus, for instance, you find that there are often laboratory abnormalities because it can be associated with infections, HIV or Lyme disease, or you can find spinal MRI abnormalities, discal herniation, but also other myelopathies that can be associated with symptomatic propriospinal myoclonus at sleep onset. It is a disease of the middle age in most patients, irrespective of the type of propriospinal myoclonus. So if you do a polymyography, then you see that it starts, that's the timeline here, and here are different muscles, up and down, so more rostral, more caudal, and you can see it starts in a thoracic level and then spreads upwards and downwards, and that's the key finding that you have to look for if you do a neurophysiological assessment. You can do a video polymyography, and then you can look at the order of muscle recruitment. But of course, you also, as usual, have also to do a clinical assessment, and there you have to look for also for a functional or a psychogenic origin. So is the pattern really stereotyped, which it must be, or is it changeable? Is there a distractibility? And then you have, of course, to doubt the diagnosis of idiopathic propriospinal myoclonus. And you should consider neuroimaging and laboratory for the reasons I just told you. What is the therapy you can use? It's frustrating. There is no evidence, there are no guidelines, there are only a few cases that have been tried. So you can try benzodiazepines, and the best described is clonazepam in very few low dosages at bedtime. There are some cases that have been treated successfully with valproic acid. There are from Japan, I think, some reports regarding zosinamide. And if there is an underlying condition in symptomatic cases, try to treat those. So now, because I had some videos, I also added cataphrenia. I hope the video works now, which is not entirely a sleep-related movement disorder. So there is an ongoing battle in the field of sleep specialists whether this is a parasomnia because it occurs mostly but not exclusively during REM sleep, or whether it is a sleep-related movement disorder, or whether it is a sleep-related breathing disorder where it is actually classified. So what is it? It is repetitive, monotonous, loud sounds, groaning, moaning, during expiration. And this occurs in clusters and mainly, as I said, in REM sleep. The significance of kataphrenia is unclear, but it's very bothersome for the bed partners because it's really loud. And if this is a problem, then we can think about continuous positive airway pressure therapy, CPAP, which is by most patients not very well tolerated with this indication. Sleep consolidating pharmacotherapy, again, like benzodiazepines, has been tried. Well, it's difficult to say. There's not a lot of evidence. So let me see. This works. I hope the sound is also here, because here we need the sound. You can turn on the sound. That would be helpful, because he's also snoring, the patient. That's REM sleep here. And here you get aware of the sound. And you understand it can be troubling for bed partners. Last but not least, some words to bruxism, because it's also very prevalent. So what is bruxism? It is a rhythmic tooth grinding or tapping. So not only this one here, but also tapping can be bruxism. It can occur in light non-REM or REM sleep, and it is often, but not always, associated with a hypertrophy of the masseter muscles. And pain is not uncommon. We may first have a look at the video. It works. Light sleep. You can hear it. You can even see it if you have good eyes. This grinding of the teeth. Not very good for the teeth. Therefore, most papers on bruxism have been published by dentists. So what is the therapy? The only good evidence is oral appliances, something like that here. So this protects the teeth. There is also some evidence that the bruxism activity per se is reduced, maybe by a myorelaxant effect, but this is not proven. If you consider other treatments, you leave evidence again. Botulinum toxin has been tried in patients, clonazepam again, which is good for everything here. Clonidine, biofeedback therapies. Altogether, we have not sufficient evidence for those. And with those words, I would like to thank you for your attention.